Okay, this is a diabetic patient with a diabetic vitreous hemorrhage, and this hemorrhage is settled inferiorly. There's some traction under the area of hemorrhage, and this just kind of demonstrates some of the fundamentals of removing blood from the patient's eye that has a diabetic vitreous hemorrhage. We're going to start with our core vitrectomy. We're going to start in the area that we have good visualization, and once we've done a bit of our core vitrectomy, now we're going to try to get in through the posterior hyaloid and find a surgical plane between the vitreous that's now separated from the retina underneath it and the retina underneath it. And very cautious in this area because with hemorrhage, sometimes you can't see, and there's elevated retina in those areas. So we're able to get in there and create that separation. And that's really fundamental to kind of completing our core vitrectomy. You want to separate that peripheral vitreous from the more posterior vitreous. And we'll shave down this inferior vitreous hemorrhage that's kind of layering here. I usually do give patients a anti-VEGF injection within a week of their surgery. And we're going to shave down here and use our cutter to kind of create some surgical planes in this area of neovascularization of the optic nerve and try to separate there. I'm going to go ahead and go in with some forceps and just peel this area of traction off the optic nerve. Now, without an anti-VEGF injection, this can be a real tricky situation with lots of oozing and hemorrhage, which you can see giving that anti-VEGF before. And with no PRP previously, it comes off very nicely with minimal bleeding at a reasonably normal pressure. I think we're running our pressure here at about 40. Now, once we have all the traction removed, and you can see some of those chronic inferotemporal changes in the retina from persistent traction, we're going to go ahead in with our laser. I will laser areas that are oozing directly and use that laser to create some hemostasis. And I find that this works about half the time, lasering areas of oozing neovascularization just directly. And then we're going to do a full PRP laser treatment. And we're going to surround this area here inferotemporally that does have some tractional elevation of the retina, so we can't get laser right up to the edge of that area of elevation, but we can get around it pretty good and try to do really good laser out into the periphery. Switch hands here so I can do that full temporal periphery. This is this patient's first exposure to PRP. Take care not to go too posterior because we don't want to create night vision issues. Little depression here looking for breaks, but when I'm depressing, I actually find that there's areas that we can fill in with PRP laser treatment. So I'm going to go ahead and do that nasally here. And then we're going to diathermize this little oozing area. It's just oozing a little too much for my liking, so we'll go in just very cautious diathermy, soft tip to kind of get up some of the hemorrhage around it. We'll laser around that area. Unfortunately, this patient didn't need any air or other tamponade. We're able to just remove our cannulas and things go real well. Thanks for watching.